Hello, thank you all for attending the first WHS webinar for 2025 on a very interesting topic, burns. Please note if you have any questions throughout this evening presentation, please utilize the Q&A box and we will address as many as questions as possible at the end of the webinar. As a reminder, this webinar is being recorded. Our presenter today would be Dr. Shawn Tejiram and our moderator, Dr. Christina Megal. To you, Dr. Tejiram.
Good evening, everybody. It's an honor and pleasure to be presenting on general burn care principles and burn care in general to the group. Let me go ahead and share my slides. And while I'm bringing it up, I was kind of tasked with providing kind of an introduction to burn care and some specifics that are inherent to burn care and related wound care management, which I'm happy to do and always excited to talk about and present burns. One caveat for our colleagues that are on our Zoom presentation is some of the pictures are a little bit graphic and it's not intended to gross you out or offend. It's more so just for you all to appreciate and understand just how devastating and severe these injuries are. What are the complexities that are involved in the management of these patients, and just how significant and serious recovery for some of these injuries are as well. So just to start this off, I don't have any disclosures. And the objectives of this are kind of, burns can present in a very complex and multidisciplinary format. So, I mean, where do we even start? And I think that this can give a nice 50,000 foot view on where you start and how you start organizing the management of these patients. Assessing burn depth and size, whether you resuscitate patients or not, or what that even means. What are some of the surgical principles, options, and topics that we do for these patients? And special populations that we see in patients that we see and manage as well. And one specific thing that was asked of me and was a common question was, when do we transfer these patients? Should we manage these patients on our own? Are we comfortable to do that? So I hope that this can give kind of a basic and fundamental um, understanding of those processes. By the way, if you guys can't see my slides or hear me, please stop me or mention on the chat and I'll adjust on my end, but I think everything's working, so we'll go on and proceed. Who am I and who are we? We are the Burn Center at MedStar Washington Hospital Center. We're the only adult burn treatment center for the Washington metropolitan area, commonly referred to as the DMV area, DC, Maryland, and Virginia, but we also care for patients on the eastern portion of West Virginia, and sometimes we'll occasionally get patients from southern Pennsylvania as well. We're the regional referral center. We take care primarily of burn injuries, but we also take care of complex skin diseases, complex traumatic wounds that require coverage, and we have a very wide spectrum of care. Not only do we have an ICU that's specific to our burn population, all the critical care management and significant wound care needs that are associated with their management, but also a step-down unit as they're recovering from either their ICU needs or their burns may not be so severe that they have critical care needs. We also have a outpatient burn clinic for the management of our patients on an outpatient basis. And we also manage a lot of the chronic wounds that are seen in and around our hospital, pressure injuries, diabetic foot ulcers, et cetera, that require extended and ongoing wound care. This is what that looks like. It's a mixture of critical care, intensive ICU management, multidisciplinary professions that are involved in care of our patients, and cutting edge research, basically focusing on basic science, translational research, and clinical research, and how they can apply to and improve our management of our patient populations. So the mix of our population can range from small injuries to, say, a portion of the hand, to quite complex, large, and critically ill patients that require sometimes months of management before they're able to fully recover and go on to their next steps of rehabilitation and management. It used to be that half of the people, or the lethal area, sometimes you can think of this in terms of pharmacokinetics, the lethal dose, where half of the patients are able to survive. The amount of burn that somebody could sustain as early as the 40s was about 40% before you would have about half of that population that would be able to survive. By the 90s, that's increased to about a TBSA, or total body surface area, about 80% of the body. And I would say probably in the 2010s, 2020s or so, that's probably increased about 90-95%, depending on patient comorbidities and their age as well. What does that look like? Well, if we look at our Lund-Browder diagrams that we fill out for these patients as they come in the 1940s, this is about a 40% burn would look like in those shaded areas. And in the 1990s, that's about what an 80% TBSA burn would end up looking like. Why is that? Well, throughout the years, there has been a number of advances in burn care that have helped facilitate mortality and improve survivability with patients with these devastating injuries. That comes from the advent and use of antibiotics and increasingly broader antibiotics, modern fluid management and resuscitative measures, early excision and grafting rather than waiting for burns to evolve over time, and the introduction of advanced technologies in skin coverage and skincare like skin substitutes. So that brings us back to one of our fundamentals. When you have a patient that presents in your emergency room or in your hospital or in your care area, where do you even start? Much like our trauma population, we start with an organized assessment of our patient population, classically known as the primary survey as taught in ATLS courses. Those are your ABCs, as we all recall and remember. What are the ABCs? Airway, breathing, circulation, etc., in a systematic format to make sure that we control for anything that we think is at risk of killing a patient immediately or within the first 24 hours of management. We do something called a secondary survey as we get a hold and sense of the patient's environment, comorbidities, allergies, etc., in order to do a full assessment of patients as they come in through our acute care facilities. For airway and breathing, not only are we making sure that the airway is open, but there are specific things that we worry about in our burn patients in terms of airway and breathing. In particular, house fires, where patients are in building or a structure fire for a prolonged period of time where they're inhaling a significant amount of smoke. Smoke inhalation is a leading cause of death from fire in this patient population, and it can be really broken down into three components: thermal injury, or burn on the inside rather than the outside, asphyxiation, or the lack of delivery of oxygen, and then the delayed lung injury from the smoke and soot that develop over time from the repeated inhalation of smoke in particulate. For the thermal injury, we have to remember that the nasopharynx acts as a natural heat sink, and the injury occurs when the amount of heat and the temperature of the heat overwhelms the ability of the nasopharynx to act as that heat sink. What do we see this manifest as clinically? Usually airway swelling, sometimes within 24 hours, most likely within the first 4 hours of injury, and we'll oftentimes do airway watches, management, sometimes direct laryngoscopy or bronchoscopy in order to evaluate, say, the vocal cords or the oropharynx for any signs of injury like this. When we're talking about asphyxiation, blocking the airway will obviously stop the delivery of oxygen to cells. But in terms of smoke inhalation injury, there are two chemicals in particular that we're particularly worried about. One is carbon monoxide. You classically hear this as carbon monoxide poisoning, or the absorption of cyanide. Carbon monoxide ends up happening due to the carbon-containing products burning in an enclosed space. Hemoglobin binds to the carbon monoxide and ends up displacing the oxygen molecules, and that leads to a lack of delivery to oxygen to cells. For cyanide, it's a little bit more insidious. You have a lot of plastics, fabrics, various materials in the house that end up catching fire, and it aerosolizes all those poisonous compounds that are inherent in those products. Those end up getting absorbed, and the cyanide itself, as you know, with cyanide poisoning, ends up preventing the cellular machinery of oxygen use. In those cases, sometimes we have to give a medication in order to prevent the absorption or to mitigate the absorption that has already occurred. And then there's delayed lung injury. All of those corrosive dust and particulate ends up getting inhaled by the lungs, and it destroys not only the respiratory tract and mucosa, but the bronchial cilia, the lining, etc., that helps us and aids us with clearing all of the debris that we naturally are able to clear over time. How do we identify this? Classically is with bronchoscopy if we need to do a diagnosis. Sometimes we have adjuncts like facial hair singeing, sooty deposits around the mouth, airway swelling, tongue swelling. Sometimes when we send an acid base, an ABG, we'll see significant levels, elevated levels of carbon monoxide or a severe metabolic acidosis that would suggest a smoke inhalation injury. And the treatment is multifold. For carbon monoxide toxicity, you want to redisplace that carbon monoxide, so you'll give 100% oxygen in order to displace that and allow binding of oxygen to the hemoglobin. You'll see a correlating decrease in your carbon monoxide levels over time as you trend your ABGs. For cyanide toxicity, you want to give hydroxycobalamin, that's classically known as cyanokit. That helps bind that cyanide and allows renal excretion. And sometimes we'll do things called a nebulizer cocktail, which is several aerosolized medications that you end up giving through an endotracheal tube in order to allow pulmonary toileting and help clear out the debris, like mucomist, nebulized albuterol, nebulized heparin, nebulized saline, those kind of things that allow continuous pulmonary toileting over a 24 to 48 hour period. As we get past our airway and breathing management and we're still on our primary survey, we get to circulation. What's important about circulation in burn patients is whether they need quote unquote a resuscitation. Administering fluids, yeah, you could consider that a resuscitation, but when they have severe burn injury, meaning the amount of inflammation that they sustain from their burns, which is a whole body systemic inflammatory response, the body usually is able to compensate for that up until a certain point. When the severe burn injury has an inflammatory response that is so great that the body is not able to compensate for it, that's when burn shock happens. Essentially, the severity of the inflammation leads to a lack of delivery of oxygen to the rest of the body. And in that case, you have to do a specific resuscitation in order to account for that, restore homeostasis as best you can, and restore fluid to the intravascular space that's being lost. How do we determine if we need to do that? If the burns are severe enough, you know. But formally, we want to assess a burn size and determine if somebody has a severe enough burn injury that they need to have a resuscitation. Most common cutoffs are about 20% TBSA, sometimes 15% or above in special populations like those who are older or have more frail or have significant comorbidities that you need to worry about. As we all know, being the Wound Healing Society and being specialized in wound care, the skin has a number of functions: vitamin D production, cosmetic, temperature regulation, fluid regulation, protection against UV radiation, body temperature regulation. When you disrupt this, even in small burns, you can dysregulate this entire system. What are the most common causes of burn injury that we usually see in this patient population? For adults, the most common cause are flame followed by scald, and in kids, it's actually flipped. The most common type of injury, burn injury, comes from scalds because they're usually pulling hot liquids from tablecloths or tables, or they're grabbing cups that they don't know have hot liquids, end up drinking something, and it spills throughout the rest of their body. When we're assessing burn size, there are three components to it. One is the depth, how deep we think the burn is, what is the mechanism, and what is the size of involved, i.e. the TBSA. If we go down in depth, we grade depth based on degree. Sometimes we call it partial thickness, superficial, and I'll get into that into a second. And I have some example burns that you may have heard about that are usually typical of that degree of burn depth. So if we get into it, a first degree burn is just the level of the epithelium, the most superficial type of burn. You don't usually have open wounds. You have more redness, irritation, and anybody who's had a sunburn before knows it usually smarts pretty badly for the first couple of days. Red, irritated, maybe some superficial peeling of the skin as you kind of exfoliate that injured skin. But you don't usually end up with open wounds, and it improves over the course of a few days, really without any sequela that you have to worry about. Second degree or partial thickness burns, now we're talking about burns that go deeper than that epithelium. Now you're into the level of the dermis. The dermis gets injured, layers of the dermis start separating, and that's how you end up getting blister formation because the fluid ends up coming into that area between the dermal separation. When we talk about deeper injuries, now we're going past the dermis. This is your third degree or full thickness burn injury. This gets down into the soft tissue and fat underlying the skin itself. The entirety of the skin is injured, and that's problematic because most of our keratinocytes and new skin cells come from your hair follicles and sweat glands. Those are all destroyed in third degree burns, and you're mostly reliant on your wound edges which is usually not adequate for the size of burn that occurs in order to heal on its own. These type of patients usually need surgery, and surgery for these patients usually means skin grafting. There are burns that are even deeper than this. They're called fourth degree burns. This is past the fatty layer down into the fascia, muscle, and sometimes the bone underlying them. We typically see this with your electrical injury burn patients, where the current from the source ends up traveling through the inside of the body, and that's what results in the burn on the inside of the body. You end up having significant soft tissue destruction, and this is the patient population that you usually see and needs an amputation. How do we assess the depth of the burn? Sometimes it's obvious based on what you see with your own eyes. Sometimes it's very mixed, it's very heterogeneous, and it's never really well demarcated a lot of the times. Sometimes we're relying on things like capillary refill. Does the wound blanch? Do you see evidence of perfusion to that wound? Do patients have sensation when you palpate their wound beds? That's a sign that the nerves underlying the injury are still intact and maybe the burn depth is not as deep as we fear. Sometimes we look for hair follicles or signs that there's hair growth, but that can be plus or minus depending on how hard you pick at the hair or the timing that you end up looking at the wound in relation to when the injury happened. So more classic things that we learn in medical school, like pinprick and proprioception, can sometimes be indicative of whether sensation is still intact. A gold standard would be biopsying, where you can look at the depth of an injury under an H&E stain, but this is sometimes difficult to do based on resources available for an institution. There's also imaging, and a lot of interest in imaging in terms of identifying how deep a burn is. Things like LDI, which is a laser Doppler imager, will use laser technology to frankly assess how well a wound bed is perfused and give you an estimation on wound healing time. There are active studies right now that are using AI-assisted visual assessments in order to determine the size and depth of a burn injury, and it's an exciting topic in our field. That being said, most depth determinations are still being made by clinicians right now. They're usually being made by experienced surgeons, aka burn surgeons, and it's usually necessary to do this under serial evaluation. Usually the wounds are either getting better or they're getting worse, but they're never usually staying stagnant. If we have a wound like these, we may suspect second degree based on the formation of blisters, but we don't really know what is underlying that wound bed until we debride and clean off the devitalized overlying skin. Sometimes it's obvious, like the back on this patient on the left, where it's very clear that it's full thickness, and sometimes it's a little heterogeneous, like on this picture on the right, where you see kind of that leathery, kind of characteristic appearance for most of the wound bed, but kind of surrounding it is this pure area of hyperemia. Sometimes it may look healed, sometimes it may look pink and kind of dry. It's kind of hard also to determine based on pictures alone, and this is why it's important for physicians and clinicians and providers to assess these wounds in person and over time serially. When you see something like this, you may have an idea that it looks deep just because of the kind of devitalized look around the thumb and the index finger, but what you'll notice right at the knuckle is some wrinkling of the skin that suggests that this is still third degree and has some devitalized skin that needs to be debrided away before you can tell what exactly is going on. We probably call this indeterminate at first until we fully clean the wound. So even then, by best clinical estimates, burn surgeons are only getting it right up to about 3/4 of the time. For those who are inexperienced, they're only getting it right up to 50% of the time. So don't feel bad if you're assessing this and you're not really sure how things look. That's why it's always good to consider calling or reaching out to um, uh, a burn center in terms of um, whether they need to be transferred or to assist with assessments. Why is it so important to assess the burn size? This dictates the fluid resuscitation volumes, and it suggests mortality in concert with other variables. We assess burn size based on two methods. We do it based on the rule of nines, and we do it based on the Palmer method. If you look at what that means, the rule of nines essentially divides portions of the human body into multiples of 9. The easiest way to remember this is each arm is about 9%, the head is 9%, and everywhere else are basically 18%. So the front torso is 18%, back, each leg is 18%. A Lund-Browder chart here on the left, even divides this even further. When you get to children, there is increased body surface area along the head at the expense of the legs. So your legs end up having smaller percentages in relation to the head, which has a larger TBSA percentage compared to adults. Now, oftentimes burn wounds don't present in a well demarcated area. Like you don't usually get a complete circumferential arm when they come in, and you can just say that that's 9%. Oftentimes present discontiguous, and you have to figure out kind of in multiple areas where that TBSA is. And that's where the Palmer method can be really helpful for assessing TBSA of a burn. It effectively means that a patient's palm is equivalent to 1% TBSA. And here's an example here of what that looks like. We would say that this patient has a 1% TBSA burn, and we can compare it pretty easily to the patient's palm to see it's about the size of her palm. Another important concept when you're assessing burns is what do the burns do over time? There's a concept of burn wound conversion that was written about by Dr. Shupp and colleagues, and it's based on the concept of the zones of injury. So if you look at this figure on the left, this is a figure from that paper, and you have these three concentric zones. The center zone is the zone of coagulation. You can think of this as the area of maximal injury from the burn, and it's the area with the most tissue destruction, the area that's probably going to need surgery, is irrecoverable, and has the most injury based on the mechanism of injury. Surrounding that, you have the zone of stasis, and I'll get back to that in a second. And surrounding that, you have the zone of hyperemia, where you have increased blood flow to deliver all of those components that are necessary for wound healing. The zone of stasis is the area of the wound that is most at risk of turning into the zone of necrosis. So all those things that we do to support patients during their burn injury, fluid management, infection prevention, antibiotics as necessary, those are all things that support the wound bed and hopefully get that area, aka the zone of stasis, to heal over time. If we're unable to do so, and it's not necessarily the clinician's fault, but due to the severity of injury and the inflammatory response that follows, that zone of stasis may convert over time and become the zone of necrosis. One way to demonstrate that is this picture in the lower right corner where you can see sequentially areas of the wound that look like they might be on the border end up converting into deeper third-degree burns over time. Now, once we decide on how big a burn is and if the burn size is significant, we have to decide on whether we need to do a burn resuscitation or not. There are a number of issues that happen after severe burn injury, and as I mentioned, after a certain size of burn injury, that results in a severe burn inflammatory response that impedes multiple areas of the cardiovascular system. You end up having a pump failure because the severity of the inflammation impedes the ability of the heart to pump and squeeze as well as it can. You end up having low fluid volumes in general because of poor vessel function. What I mean by that is your capillaries and blood vessels end up becoming more leaky. All those connections between the endothelial cells end up separating. And not only do you have more fluid coming out of the blood vessels because of the hydrostatic force from the heart, but you're also losing protein into the space between the blood vessel and the cells. And that results in less fluid in the tank, so to speak. You have less fluid returning to the heart, and that leads to less fluid being perfused to the entire body and less oxygen delivery. We have a couple of ways of mitigating that, and kind of superficially in a nutshell, it depends on restoring the fluid in the tank and trying to restore as best we can the protein in the tank as well. The most commonly known formula, and probably the most widely used globally and still in use, is the Parkland formula, classically known as 4 cc's of LR times the patient's weight times the percent TBSA. Here in the West and the US, we go by the ABA consensus formula, the 2 cc's of LR times the weight in percent TBSA. And the reason for that is there's been a lot of literature that shows that even with Parkland formulas, we being the burn population, tend to get more fluid than expected, even when we try to control for things. Based on that literature and the complications that we see, and I'll get into that in a few slides soon, there has been movement towards less fluid administration and trying to use additional adjuncts to help us get lower volumes in patients while also facilitating the resuscitation. The ABLS, which is the American Burn Association's version of ATLS for burn-specific care, recommends the consensus formula. And for special populations like electrical injury, where you see evidence of muscle breakdown, aka myoglobinuria, we actually do favor that higher fluid volume in order to help flush out any muscle lysis and help perfuse the kidneys a little bit better. How do we decide how to titrate the fluids? Well, the most common thing that we use is urine output. This has 30 to 50 cc's per hour, and it basically breaks down to about half a cc per kilogram per hour in your average size patient. Other endpoints of resuscitation include a base deficit, which has been classically studied and has been shown that worsening base deficit are probably signs of more severe inflammatory response or indicators of possible future ARDS or multi-organ dysfunction. Normalization of this has associated with improved survival. Other things have been looked at like lactate and has been associated with mortality with elevated lactate, but there isn't really a clear threshold value, and it's a kind of a more broader lab sample than necessarily acid-base status or base deficit. Our fluid of choice is LR, but sometimes we'll try to restore that oncotic gradient and restore our protein with albumin or FFP. There are certain burn centers that choose the type of colloid that they end up using. We tend to use FFP. There are other adjuncts that have been examined and described, but all of these other ones like hypertonic saline, dextrans, hetastarch, vitamin C have been associated with more complications. There have been studies that looked at the average volumes that patients have received over time. And as you can see with this, looking at a patient's 24 to 48 hour period of resuscitation, when we look at the fluid volumes and rates that are being administered, you can see in that first 8 to 12 hours following injury is when the infusion rate is the highest, suggesting that the most maximal inflammatory response ends up happening in this 8 to 12 hour range before it starts decreasing in size as resuscitation and perfusion occurs. You also notice that it never goes back to normal, but it does decrease over time. Now, as we're resuscitating patients, we have additional concerns that we have to look at and look out for. For circumferential deep burns, you lose the pliability of the skin and the ability to expand. And sometimes the muscles and everything underlying the eschar end up swelling, but the eschar prevents that swelling from being facilitated. So we'll have to do something called an escharotomy, where we open up that eschar and help facilitate egress of the soft tissue and components underlying it. Sometimes we'll have to do it in different areas of the body. One thing that's classically happening with circumferential torso burns is that eschar prevents the chest wall from expanding adequately to allow ventilation, and we'll have to open up the eschar in order to facilitate ventilation in these patients. Sometimes if the severity of swelling and edema is significant enough, we'll have to continue with our eschar down to fasciotomies in order to open that. It's not just the extremities that we have to worry about. Organs are special areas that we have to worry about as well, where the organs end up swelling up and become edematous, and we have to release certain compartments like the abdomen in order to allow those organs to continue swelling in order to prevent additional injury. So when we get past the resuscitation part of it, now we're kind of getting into the wound care, whether that's topical wound care or surgical management. What you can see on this slide is we generally try to do excision and grafting as early as we can, but we kind of have a rule in the burn community where if something doesn't heal within 2 to 3 weeks, it's very likely not going to heal and may represent an infection source while the wound remains open. Some common topical therapies that we use include silver sulfadiazine. It's a 1% cream. It's safe, relatively painless, relatively inexpensive. And it has minimal side effects. I think the most commonly described side effect would be neutropenia. This is the molecule here on the side. You can see that the sulfide component of this is covalently bonded to basically everything. And a common question that we get is any patient with a sulfa allergy, would you avoid silver sulfatizing? We actually don't avoid it because there isn't really an opportunity for the sulfa moiety to interact with anything. And we've used it successfully before with patients with sulfur allergies without any untoward allergic reactions or any issues otherwise. Other things that we've used and continue to use include sulfamylon. This is effective against organisms including Pseudomonas and Clostridium, and it's probably the best at penetrating burn eschar. We'll end up using it in areas with cartilage just because it penetrates the cartilage so well, like the nose and the ears. But one thing you have to remember is that this is fairly painful with application. So we're very selective and careful with our application of this product. The other thing to remember is that it's a carbonic anhydrase inhibitor, so use in large areas of the body can cause metabolic acidosis, and that's something that we look out for with serial blood work in our patients. Acticoat is an ionic silver. It's activated silver in a containing cloth and gives a little bit more of a controlled release of silver over time. It can be used in combination with various solutions. Sometimes we'll activate it with water if we're putting it on a particularly dry area. And it has a broad spectrum of antimicrobial coverage. It is a little bit more costly compared to some of the other examples that I've provided here, but it does have its uses and it can have a lot of utility depending on the use. For example, if you're using it in certain areas or as part of your operative dressings, there are specific areas that you would consider using Acticoat. Aquaphor is another topical that we use. This is not an antimicrobial topical. We'll usually use it in healed skin or healed areas as to kind of support and continue with the healing process and support healed areas. It's painless, safe, cheap, it's a moisture barrier. It doesn't really have side effects associated. So I think, topical antimicrobials are quite a wide variety that you can use for the management of these, but I think these are probably a good summary, kind of 50,000-foot view of some of the topicals that we end up using for these patients. Same for surgical interventions. I think everybody can see on the left-hand side the classic scalpel that we all know and love, especially for any surgeons that are on this presentation. But if we look in the middle, that is a WEC blade that allows us to do tangential excision and kind of a careful excision to see what kind of eschar we can remove and at what level is the wound bed healing. Above that is a Humvee knife, which is a much larger blade and allows us to go deeper faster. And below that, at the very bottom, is a Norsen debrider, which allows kind of superficial scraping and allows us to kind of interrogate and assess a wound. Top right are dermatomes that allow us to harvest skin whenever we're doing any type of procedures that require any grafting with a patient's own skin. And on the bottom right is a VersaJet, which is a high velocity hydrojet that again allows us to do kind of superficial debridement or deeper depending on how we use this tool in order to assess wounds and allow excisional debridement. What kind of things that we can use to cover a wound bed? Autograft is probably the most well-known, auto meaning the patient's own skin. You can see on the left here, harvesting of skin, and then in the top middle, we'll put it through a mesher that allows us to expand the skin area of coverage for a given donor site that we get. You can kind of see this grid-like pattern in the picture in the bottom middle, but if you see it on a patient, you can kind of see where that grid-like pattern goes. So in essence, we can cover more wound bed with less skin by allowing meshing. Now, the diamond pattern, mesh pattern needs some time to be filled in, and that fills in from the wound edges of the skin that we end up laying down. So while we can widen that, it does take longer to heal if we do that. And we have special strategies to try and mitigate that if we're using higher mesh ratios. If a wound bed is infected, inflamed, edematous, it may not be ready for a patient's own skin. Whenever we're creating donor sites, we have to remember that we're creating wounds that cover wounds. And if something isn't ready for their own skin yet, we don't want to put their own skin on it too early for fear of the graft not healing, leading to graft failure, and then you're left with nearly double the amount of wound burden that you started off with. At this point, we'll start considering things to cover wounds temporarily while all that inflammation and edema dies down before somebody's wound bed is ready for their own skin. Options include things like allograft. This is cadaver skin that we can lay on a wound bed, and we can lay it on for several days and sometimes even weeks before a patient is ready for their own skin. Kind of classically, xenograft meaning not of human species. The classic one that we used to use with porcine or pig graft, as displayed here. Fish is another one that's been described and is used at some institutions. Um, Other things, if the wound bed is so deep that we're down to muscle, sometimes we have to recreate that dermis or a neodermis or a granulation layer because we can graft onto muscle itself, but it will adhere to the muscle. You'll see the muscle in the skin graft. Sometimes it's difficult for patients to move as the muscles flex and pull on the skin. So we try to lay dermal regenerative templates down for especially deep wounds in order to help recreate that dermal element and have it ready for a patient's own skin. On the left here is Integra. On the right is Polynovo biodegradable temporizing matrix, and each have their own applications based on the wound bed and the size and location. Other things include skin substitutes. One that we use pretty commonly here is something called Suprathel, which is a synthetic polylactate. It's kind of indicated for partial thickness wound beds. It helps provide an epithelial covering. It allows patients to leave the hospital earlier. Since they don't have daily dressing changes after you apply this, their wound burden and pain management needs end up decreasing with its use. And Another thing that we'll use to kind of strategize wide wound bed coverage is autologous skin cell suspension, sometimes classically known and heard as spray on skin, where we'll take a small area of skin, place it in trypsin, separate the keratinocytes, and put it in a solution that allows us to spray a wide area of skin cells onto a wound bed. Some examples of Suprathel, this is a partial thickness grease burn to a forearm and part of the hand that we ended up placing Suprathel on, and as we saw them in clinic over time, this ended up healing without any major skin grafting needs. Here's another example of a scald to a back. You can see here in this picture some of the adherent Suprathel still remaining on the back with some dressings on top of it, and how it's able to heal and even maintain the tattoo that was originally there over time. And this was a patient that was in a house fire with severe flame burns to the bilateral arms. We actually did a second application of Suprathel with an autologous skin cell suspension on them. And this patient ended up healing over time as well without the need of any autografting or other procedures. Other things to appreciate with this population, especially given the location of the grafts, we got to have something on there that helps the grafts heal. On the left, you'll see a wound vac that allows us to provide some kind of even pressure over a skin graft and also allows us to suction out any fluid that's developed from the wound bed. And on the right, you can see a tie-over bolster for areas that's difficult for us to place a wound vac or we're not able to get a wound vac on to allow kind of measured pressure over an area in order to get a graft to heal. Some special populations I want to highlight as we get to the end of this presentation: mixed burn and trauma patients. Can be quite complex and have competing injuries that need to be addressed while we're managing burn wounds. Excuse me. There's variable incidents in the literature, highest of which is in motor vehicle collisions. Sometimes you see it masquerading as child abuse. But the thing that I want to highlight with this slide and this graph is that as your body surface area burn injury increases and your injury severity score increases, you do have an exponential increase in mortality. So obviously the added burden of traumatic injury adds a lot to the management and mortality seen with these patients. As I mentioned, car fires are probably the most common thing, but you'll see them with patients escaping structure fires where they jump from a window or if they have associated lacerations escaping. Electrical injuries will cause tetany-induced fractures where the muscle ends up contracting so hard you'll have long bone fractures, and you have falls associated with that, as well as explosions where you have projectile wounds or shrapnel that you end up having to account for. When we're managing these patients, we're obviously dealing with the life-threatening issues first, and for trauma patients, that usually involves bleeding before we're getting to the burn shock and management. But We try to manage the burns and the resuscitation as best we can as we're trying to get through all the life-threatening injuries that need to be managed. For patients with burns who have diabetes, we have to remember that the issues are that it's a combination of a microvascular disease, so they already don't have good blood flow to begin with, and they have neuropathy, so they're not caring for their feet as well as they can in terms of trauma or bumping into things or whatnot. They end up having a higher length of stay per percent TBSA compared to the general population, just because of all the comorbidities that are associated with it. And the key concepts for management, in addition to their comorbidity management, is specifically hyperglycemic control, so you can optimize the wound bed from the hyperglycemia that may be affecting it. And then also optimizing the vascular flow that may manifest as angiography with interventions in order to improve vascular flow to a given area. And an area that we think might be deep and very difficult to manage may be able to heal even somewhat before surgical interventions or skin grafting when there's optimization of those comorbidities and vascular flow. We also see a lot of cold injury patients, and the problem with this is that it's a delayed tissue injury caused by a multitude of things, as I'll get into the next slide, but it's really a combination of ischemia and lysis of cells in combination with microvascular thrombosis. It may not seem that bad at first, but we oftentimes see these wounds evolve fairly significantly over time after the initial inciting event. And as I mentioned, it's a combination of injuries to the cells themselves. So you can see in the schematic here on the left, ice crystals forming around the muscle cells and cells themselves. And then kind of in the middle of that figure on the left, the microthrombi that end up developing in the vasculature itself. Presents usually kind of hard and waxy looking. Patients may experience clumsiness because of the joints and stiffness involved in it. And for advanced disease, you might actually see blistering over affected areas, especially areas as they're going through the reforming process. This is a paper out of Hennepin where they effectively graded frostbite injury and came up with a numerical score that as that score increases, the likelihood of amputation ended up occurring. And they took that score and ended up looking at those patients who ended up with amputations when they presented with frostbite. And the things that they found were increasing age, increasing frostbite, and the time to thrombolysis were the biggest factors in the risk of patients who end up getting amputation following frostbite. So management principles, we want to address the hypothermia, we want to remove anything that's facilitating hypothermia, and we want to be in warm water baths. We also want to keep in mind that these can be very painful in terms of rewarming practices. So we want to make sure that we have good opioid needs and non-opioid adjuncts as well to control pain during the rewarming process. We have to remember that the hypothermic response and all the things associated with that, like shivering, increase oxygen consumption. And from a critical care perspective, sometimes we have to account for that from a resuscitation standpoint. We have various methods of rewarming our patients, simple things, warm blankets, increasing the room temperature plastic wraps, to fairly invasive things like esophageal warming probes, lavages of various body compartments, managing the mechanical ventilated air in our critically ill population, to even CRT, dialysis, and ECMO if we get to it. Thrombolytic therapy, we're considering it when we think there's a risk of tissue loss that could be salvaged. Usually we're treating this within 48 to 72 hours, and this is something you especially want to consider transfer to a specialty center, especially because we can trend Doppler signals or vascular exams while we're assessing for indications for thrombolysis. There's no clear advantage for intra-arterial versus intravenous. Whatever is really the fastest option is what the literature is currently saying in terms of thrombolytic therapy. As the old adage goes, time equals tissue, and you want to try and get these lysed as quickly as possible. For these patients, we're not usually operating on them. We're giving them time for the dry gangrene to demarcate itself out for fear of an evolving process. We don't want to operate too early if the wound edges that we close are going to become necrotic over time. However, that being said, when there's signs of infection, i.e. wet gangrene, That's what prompts earlier and often emergent surgery. These are what leads to our guillotine amputations in this patient population. Once these patients heal, they still stay with us. They end up developing significant scar or symptoms related to their healed wounds, and we end up having to provide a fairly extensive reconstructive and aftercare program for these patients, both for them to recover from their healed wounds, manage any severe scar contractures that they develop, and help aid them with reintegration into society. Aftercare may manifest in multiple ways for management, including pain or ongoing open wounds that they have, or new open wounds that develop over time. We may have to assist them with their mobility, have continued rehab needs and rehab follow-up, and manage any psychological issues that develop in relation to their injuries and management afterwards, including post-traumatic stress and anxiety. Study literature has shown that even things as simple as support groups can help with this reintegration process. And they showed that survivors who attended at least one support group in this study scored higher on scales of social interaction, social activities, and even work and employment. So there is benefit to um, uh, uh, group meetings and group care. These patients end up developing a relationship with us even far advanced from their hospital course and hospital management. And we end up becoming involved with these patients' lives over a number of years as we continue to aid them and help them with any ongoing issues after their injury, after they've healed, and also during their reintegration process into society itself. We also aid patients with any cosmetic issues that follow injury and aid them with normalizing their scars or trying to get them as normal as possible. Finally, if you ever come across a burn patient, whether in a hospital or acute care setting, you may be wondering what are the indications for reaching out to a burn center for aid or for transfer. I like to say that you're never wrong if you reach out to a burn center, even if the burn is perceived to be small, little, or anything like that. We can usually get them assessed by our team. We can get them integrated in our hospital system, set up follow-up, topical care, etc. So it's never wrong to reach out to a burn center, even if you have a question. There are specific criteria put forth by the American Burn Association, including partial thickness wounds greater than 10% TBSA, burns involving sensitive areas, including the face, hands, feet, genitals, perineum, any third degree burn, because we know they're going to need surgery, chemical burns, inhalation injury, electrical injury that all require specialized care, significant comorbidities where you need specialty care for management of that comorbidity, concomitant trauma, as I mentioned, or any patients that we think may have special rehab needs, social or emotional needs. Things to consider when transferring: if the burns are significantly elevated, greater than 10%, you want fluids. Greater than 20%, ABLS teaches starting LR at 500 cc's an hour before they get to a burn center for further assessment. And for patients that you think could follow up in clinic, you got to assess the patients and make sure that they can tolerate follow-up within a week without any major complications. For us, our teaching is Sylvadine is almost never wrong, and we want to make sure that the wounds are being washed daily with soap and water for any management. Rarely these patients need antibiotics unless they're far out and they're demonstrating obvious signs of infection or cellulitis. As I mentioned, ABLS is a great reference and kind of a underpinning point for acute burn care management and supporting patients for their transfer to a burn center. And with that, again, I'd like to say 50,000-foot view, but I hope that this gives you an appreciation of what burns are, how severe they are, what are kind of the special populations amongst many that we end up seeing and managing, and when you think you need to get a burn center involved for the management of this. In making this presentation, of course, I need to thank the multidisciplinary team that I have at our hospital at MedStar and our burn center. And of course, I couldn't do this without the help and guidance of my mentors and colleagues, and that includes my partners, Dr. Shep, Dr. Travis, and Dr. O. And with that, I'll go ahead and open it up to any questions. Thank you all for listening to me. Sorry if I went over for a few minutes, but I do appreciate you all listening to me. Thank you.
Thank you so much, Dr. Tejiram. That was an incredible, very thorough overview of a fantastic, sounds like a fantastic burn program that you have. For everybody who's on the line, if you have questions for Dr. Tejiram, please enter them into the Q&A session, and I will review those and bring them forward for discussion. The Q&A should be found on the bottom of your screen, and feel free to type those in as you think of them. While folks are thinking about questions, there aren't any in there just yet. I had one for you from the presentation. You mentioned early on it when you were just introducing your team and the work that you do participate in research as well. So one of the questions that I thought of is, what do you think is one of the most promising findings in the burn research realm on the horizon, in your opinion?
I think that's a great question. And I think what's amazing about our research program, as I mentioned, is we not only do basic science, we do translational and clinical work. So anything that you see coming through kind of the full gamut is just really amazing to see. I have a particular interest in resuscitation, as do my colleagues and my director, Dr. Shupp. And in particular, what excites me is kind of the advances that we're seeing in resuscitation practices, even now. With the debate on albumin versus FFP and whatnot, our group has been able to demonstrate a lot of progress with the use of plasma in various avenues, inflammatory markers, amelioration of glycocalyx injury to the blood vessels, and seeing how that plays out clinically with improvements in resuscitation, improvements in more rapid delivery of colloids to these, and how their wounds end up responding to this in the first 24 to 36 hours as you improve your resuscitation practices. That's been fairly amazing to me as an intensivist and a burn surgeon.
Awesome. Thank you. That's fantastic. We have one question from Daniel. He asks that scarring wasn't mentioned too much as a problem after healing. Are you able to comment on how the drugs or the cell-based approaches or the synthetic coverings affect scarring?
Another question that I think is excellent. I would say in terms of the dermal matrices and the skin substitutes, that's an area that's still of active study in terms of the severity of scar that develops. What I can tell you anecdotally is that scar does develop in these patients, and I would still say is patient and mechanism dependent. Obviously, when you have a deeper injury, you're going to have a more severe scar, and the more reconstruction that's necessary in order to close a wound will result in more scar. But I do think I have to pause there because I think that it's still an area of active research. So the effects on the severity of scar formation, I think, are still actively being studied, and I don't want to speak ahead for anybody who's actively studying. It is something we're still very interested in, and it is something that we're looking into in terms of research priorities.
Fantastic. Thank you. Still have a few more moments for questions. If anyone in the audience has any others they'd like to. He says, thank you very much for the answer, Daniel. Fantastic. While we're giving folks, again, a few more moments to enter any questions that they have, I'll throw another one out there. You did, on several slides, had the opportunity to talk a little bit about using the silver sulfadiazine cream or the thermazine cream as kind of a go-to and can't go wrong. There are some warnings that come with that type of medication and a fair number of possible side effects that can happen. Have you seen, since you're using that so regularly in practice, have you seen any of those side effects, the negative outcomes from using that cream?
I have to be honest with you, we haven't really seen any.
Okay.
I know the neutropenia is classically described, but we very rarely have seen that, if at all. And we're able to use it fairly liberally without really any major side effects.
Fantastic. Awesome. All right, we have another question from the group from Veronique. She would like to know, how are you covering patients that have third-degree burns and an 80% total body surface area affected when they don't have enough autograft area to be able to utilize?
That's an excellent question as well. And I'm reminded of a patient that we had last April with about 75% of her body burn. There are a couple of strategies for this, but effectively, the first thing that you need to try to do, in addition to the resuscitation and critical care management of this patient, is try to get as much burn off as quickly as you can. And we'll oftentimes use a lot of those temporary coverage that I mentioned. In this patient's case, we used a lot of allograft, and we'll end up favoring a lot of allograft in the early management of these patients. When we're trying to get patient skin coverage, there are a couple of strategies. As I mentioned, we mesh skin so that we can cover a wider area with less skin. And as we get to our significantly wider mesh grafts, the interstitials, that diamond pattern, ends up expanding. So we try to have a couple of strategies in order to fill in those areas so to help assist with wound healing. One strategy includes using the higher mesh ratios, but also with autologous skin cell suspension over the wound bed. Sometimes we'll put that combination of those two things with allograft over it in order to help cover any exposed wounds and assist with wound healing, but minimize exposed wound beds. This is actually called the Alexander technique, or kind of classically known as a sandwich technique. For those especially elevated TBSA burns where it's very difficult to get skin, we'll take a biopsy and we'll send it to have cultured epithelial autograft grown in a lab. And if our patient survives and we have a great enough wound bed to facilitate application of that, we'll get that cultured epithelial autograft and lay that onto the wound beds. I've very rarely done it myself anecdotally, but in the times that we've done it, we've used very high ratio mesh autografts, usually like 6:1, and then lay the CEA on top of it. And nowadays, with the technology, we'll even add the autologous skin cell suspension to it.
Great. Thank you. Looks like we have time for one more question. Janice wrote in a question asking, are there studies that support one type of topical wound therapy over another, especially as far as healing rates go?
That is a very controversial topic, and I think it depends on who you ask. What I can generally say is that there is a lot of studies on topical wound care strategies in general, some positive, some negative. And as an example, I can even talk about Silvadene. There are some programs that think Silvadene inhibits cell growth and may actually be detrimental. We have not observed that in our practice or anecdotally, but some centers have demonstrated that. Part of this is what works for your center and your patients. Part of this is evidence-based. And while there is ongoing debate for the topical products that I have presented, there is literature supporting its use, wound healing, and facilitating wound healing as well. The last thing I'll say about that is there isn't one perfect dressing. Every dressing kind of needs to conform to the patient, the location, the bacterial coverage, the severity of the wound, the type of wound, and whatnot. So there's a lot of antimicrobial selection that goes into topical strategies for these ones.
Excellent. Thank you for addressing that. This takes us to 5:15, or 1 minute to go. So I'm going to turn it back over to Mohammed for our closing.
Thank you very much, Dr. Megal and Dr. Tejiram, for the wonderful presentation and the discussion, which we have a lot of questions. We can answer those offline because this is a very interesting topic, and also the research in this area is very fertile. And I would just conclude today's session. Thank you all for attending the WHS webinar brought to you by the WHS Education Committee and WoundHealing U. As a reminder, the recording will be available in your member-only account on the WoundHealing U and the WHS YouTube channel in the next few weeks. Join us for our next webinar, March 18th, on spinal cord injury with Dr. Letitia Graves. Thank you all and have a good evening.
Thank you, guys.
Thank you.